We have a lot of new therapies that are being developed in clinical trials, and we're very excited about some of these longer acting levodopas, oral preparations that may last 6 or 8 hours, continuous subcutaneous infusions that'll last 24 hours. And we're also interested though in some of the new medicines for non-motor symptoms, for psychosis, for orthostatic hypotension on a neurogenic basis, perhaps for sleepiness during the day, for constipation, all these being investigated. And maybe the alpha-synuclein antibody studies that may wind up slowing the progression, or a drug that may help people with GBA Parkinsonism, are very exciting in seeing if we can hopefully slow down the course of the disease. So we recently completed a trial that really looked at the use of subcutaneous apomorphine in trying to help patients who wake up and have trouble moving. They have early morning off, so morning akinesia. And we found that patients who entered this trial had on average about an hour while they waited for their first oral levodopa dose to work in the morning, probably due to gastroparesis. And the pill's probably sitting in the stomach, it doesn't get into the intestine where it can be absorbed. So we taught these patients how to use subcutaneous apomorphine injection, found the right dose that worked as well as the levodopa, and was able to demonstrate that it provided a very rapid onset so the patients could get up and get on with their day, but it also was much more reliable. And even in patients who had dose failures, where the first dose didn't work at all, when they took the apomorphine subcutaneous injection, there were very, very few dose failures compared to when they took their oral levodopa. Again, attesting to the benefit of trying to bypass the GI tract and giving medicines by other routes to try to get a quicker onset of action. Orthostatic hypotension is very common. It's common in people as they age, and it's common in Parkinson's disease. And what's been more recognized lately is that this is on a neurogenic basis in most patients with Parkinson's disease. That is, it's failure of the baroreflex to maintain blood pressure when patients stand up because of a loss of norepinephrine. And when this happens, you don't have vasoconstriction in the splanchnic circulation and the lower extremities. And one of the ways to test for that clinically is to check a heart rate when they stand up. So when a patient stands up and the blood pressure falls, heart rate should increase by more than 15 points, usually by 30 or 40 points. If it only increases by a few points, that's a real clue that it's a neurogenic basis for orthostatic hypotension. DaTscan allows us to image dopamine transporters, really a biomarker of presynaptic dopamine neurons. And this processes go up in the striatum, and when you lose these neurons, you lose dopamine transporters in the striatum. So it really differentiates between those disorders that have nigrostriatal dopamine degeneration and those that do not, and can really assist in the differential diagnosis if the clinical examination and history isn't so clear as to whether there's a loss of dopamine neurons or not. DaTscan can really identify those that do have a dopamine degeneration from those that do not.